Good day, everyone. John Ward here. I was asked to sort of moderate this discussion of prevention and to give a few opening remarks to sort of set the stage. It's great to see so many colleagues in the room, and one of the main goals of this meeting, as Jordan pointed out, was interaction and discussion. So we really want to get through these remarks as crisply as possible, and then really get to a discussion. I will be joined by Mark Tyndall later after following me. I was also asked to provide some details about the hepatitis B vaccination program in China because one of our invited speakers was unable to attend at the last moment. And as a result, I really will be touching on two of the most remarkable achievements, not only for hepatitis elimination, but really in the history of public health, and that's the hepatitis B prevention in China and hepatitis C elimination in Egypt. Our elimination goals are possible because we have effective interventions that I'm sure almost everyone in this room are very aware of. Highly effective vaccinations, prevention of this blood-borne viruses, hepatitis B and hepatitis C transmission by interrupting exposures through parenteral exposures in particular, but also sexual transmission, particularly for hepatitis B, and then the testing and treatment that makes reductions in mortality possible. So those are our key interventions that WHO has set out for us that need to be monitored to represent effective implementation of these interventions and progress toward these elimination goals. Vaccination, prevention of mother-to-child transmission through additional interventions, interruption of exposures through blood exposures, and then testing and linkage to care. And we're going to touch on various aspects of these. Really, the cornerstone of hepatitis B elimination certainly is hepatitis B vaccination, which we've had available since 1982. It's highly effective, confers long-term protection, at least 30 years, if not more, booster doses are not typically indicated. The timing of vaccination is very important for children. As we know, the interruption of mother-to-child transmission requires vaccination very soon after birth, preferably within 24 hours. And then infant immunization is needed to interrupt horizontal transmission because those two modes pose the greatest risk of chronic infection, which is the greatest risk of mortality. And these studies through the 1980s and into the 1990s and forward have shown the reductions in the risk of mortality, particularly from liver cancer, that is conferred through high vaccination coverage for cohorts such as the one in Taiwan, one of the first areas that began routine infant and birth dose vaccination. Now, one of the key reasons that that hepatitis B vaccination is having a big impact is because of support through partnerships such as the Global Alliance for Vaccine and Immunization. I'm now working at the Task Force for Global Health, which was developed and started in the 1980s in an effort to make vaccines more affordable for low-income countries. Fortunately, that was taken over by Gavi beginning around the year 2000, and the first vaccine that they took on to provide to low-income countries was the hepatitis B vaccine, and they've had huge reductions in deaths as a result of the Global Alliance for Vaccine and Immunization program. So getting this key financial aspect was one of the key areas that made high vaccination coverage possible. As you can see here, we now have 84% coverage globally, and almost every region has achieved fairly high coverage with that infant immunization. So in addition to financing, we're speaking a lot about integration today. Integrating hepatitis B vaccine into combination vaccines was another key strategy that it makes this high infant immunization coverage possible, and has contributed to large declines in HBV prevalence among vaccinated cohorts of children, which is one of the indicators for progress toward the Sustainable Development Goals that were put in place several years ago and is monitored by WHO. Our biggest challenge for vaccination is the birth dose. Infants who become infected at birth have about 90% chance of remaining chronically infected. Some regions have done very well, such as the Americas and the Western Pacific, and some areas, in particular the African region of WHO, are lagging. So you've achieved this parity in infant immunization, but you haven't achieved that for delivery of the birth dose, particularly in Africa. And this may be particularly important. There's data showing that for infants infected at birth, they have a higher risk of liver cancer in later life. They have a higher risk of becoming chronically infected, and with that chronic infection, they appear to have a higher risk of morbidity and mortality. So adding to the importance of providing birth dose, including in countries of Africa. There's some good news on that front is that last year, the executive board of Gavi approved support for hepatitis B birth dose for Gavi-eligible countries beginning next year, well, 2021, pardon me. So that's good news for these countries. Now that support will not pay for purchase of hepatitis B vaccine because of the cost is below the 40-cent threshold that Gavi has set for all vaccines. So they really are looking to see how they can use resources for implementation. How do you change maternal and child health programs to integrate hepatitis B vaccination immediately after birth? And what are some strategies relevant to the various countries? Particular issue for Africa is the high proportion of births at home. And how do you reach those, and what particular strategies can be brought to bear? In many African countries, there's a sense that we have decreased prevalence so much with infant immunization that we don't need birth dose. And they really want data to show the benefits of birth dose and the cost effectiveness of changing their systems. And some countries have already sort of taken the step toward birth dose implementation, whereas others are really looking to see what data can be brought to bear for their decision making. And there's a lot of work that needs to be done to help these countries go through that policy and implementation process. Now, one large example of the benefits of a hepatitis B vaccination program is the Gavi-supported project in China. China, at one point, almost 50% of the burden of hepatitis B was in China. You can see an estimated 120 million people affected by chronic infection in 1992, almost 10% prevalence in that highly populated country, 60% with any evidence of infection. The objectives of this project was to integrate hepatitis B into what's called the EPI, or Expanded Program on Immunization program of China, make sure injection safety was being implemented as well, and they set targets for implementation. They really focused on counties in the middle and the western part of the country, which tend to be low income and tend to have real issues in healthcare access. Fully implementing the hepatitis B vaccine program in China using Gavi money would have taken all the Gavi budget in total. So there was a cost sharing between the national government and Gavi, with Gavi paying really for certain aspects of evaluation and some certain program gaps, but otherwise being supported by the national government. They put together a logic model recognizing the need to educate communities as well as educate providers, the need to implement models of implementation for integration of the birth dose, as well as integration within their EPI program for infant immunization, and then they had certain outcome and impact targets. Some of the key elements of the program, obviously, was healthcare worker training, really bringing them up to speed and make it clear to them that this was now part of their work. data to monitor implementation so you can feed back for quality improvement, incentives for hospital deliveries. They had a huge shift in where births were happening, from home to facilities, as you can see there. And they built more facilities. They created financial incentives for mothers to give birth in facilities, and then integrated those into maternal and child health programs within those facilities. And as a result, they had increases in hepatitis B vaccination in all, so that the counties in the central and western parts of the country that tended to be the ones with the poorer access began to approach the coverage that was already being seen in the more affluent eastern counties. They had high coverage as a result for both 3-dose Hep B vaccination and birth dose. And these are the outputs. They achieved 85% prevalence of antibody among children 12 to 23 years of age. They decreased prevalence from almost 10% to less than 1%. And representing a 97% decline in surface antigen positivity with that increase in immunization coverage. And it's estimated that prevented 28 million chronic HBV infections and 5 million deaths as a result of that program. So really a remarkable implementation story reflecting political commitment, financial-based planning, feasible implementation of effective interventions, and then data to track progress. So as China set about with this ambitious program, the Western Pacific region, beginning in 2005, set elimination goals for all the countries in that region, including China, obviously, to implement integrated hepatitis B vaccination for infants and birth dose vaccination. They set goals originally at 2% and then followed by 1%. The countries in blue are those that have already been verified as reaching those goals, and that verification continues. I'm one of the members of this verification process. And this is the region in the world that has had the highest prevalence of hepatitis B for many years. So as your birth dose and third dose completion of the 3-dose series increases, the prevalence has fallen in this region, and they have successfully reached this 1% target as a region. So goals do matter. Targets do help. So when we think about prevention of hepatitis B, we really think about it with vaccine as a cornerstone, that infant immunization, followed by birth dose, followed by, whenever possible, maternal screening of hepatitis B, so that you can also deliver hepatitis B immune globulin, if available, to that infant at the time of vaccination, immediately after birth. Or increasingly, there is data to show that there's a role for antiviral prophylaxis, particularly for women who are delivering that have a high viral load. So there have been a number of studies that have shown some value in antiviral prophylaxis. We did one at CDC in Thailand that did not show benefit because of the effectiveness of their vaccine program, essentially, because they deliver a timely birth dose so quickly, within 3 hours of birth on average, and then follow that by a 3-dose series of infant immunization, that there was not as much breakthrough of HBV transmission from mother to child in Thailand. Again, showing you the importance of birth dose and completion of the series, but there is a role for maternal screening to deliver these other interventions when available, to add and really make elimination possible. So regions are now beginning to look at triple elimination strategies of bringing together maternal screening for, in this case, syphilis, HIV, and hepatitis B, and then deliver the interventions based on that information for all three of those conditions. In the case of the Americas and Latin America, they've added Chagas disease to that. But I think as long as you have that bedrock foundation of immunization, these triple elimination strategies make a lot of sense to complete that elimination target. So now look at interrupting blood-borne exposures of hepatitis B and hepatitis C. This is really a success story. If you look at the history of disease elimination, one of the tenets is that progress toward elimination doesn't have to start when you set the goals. They can start much earlier, and that's certainly been the case for improvements in blood banking and in infection control, where there's been an estimated large decrease, almost 90% decreases in the risk of transmission in healthcare settings because of the implementation of HCV and HBV screening of the blood supply and improvements in infection control. That said, there's still about 1.2 million HCV infections related to exposures in the healthcare setting. You know, from Western countries, and we often think about people who inject drugs, but in actual fact, exposures in healthcare settings is the major mode of transmission for people with hepatitis C. So efforts need to be sustained and enhanced to prevent and interrupt transmission in healthcare. Now, there are certain areas of the world, such as Pakistan, where people get large numbers of injections on average, up to about 18, I believe, in Pakistan, because there's a cultural preference for injections over oral medications that are equivalent in potency, which only increases the risk if you don't have good infection control, because you're not using auto-disposable syringes and other interventions to make contamination less likely. So there still needs to improve infection control, even though we have made great progress. So really, when you come to transmission of HCV, you have to really think about people who inject drugs as the highest risk population, as we well know. With about a 60% prevalence, virus is transmitted very readily after the initiation of injection behavior. Obviously, those persons, the more you inject, the higher your risk. As I've already mentioned, the proportion of people with HCV that have this risk behavior varies widely around the world. So knowing your epidemiology does matter, so that you can prioritize your interventions to where they will be most effective. You know, we know that certain interventions interrupt transmission of HCV among people who inject drugs. The most powerful is access to drug treatment. Secondly is access to safe injection equipment, and when you put those two together, it's you have about a 71% decline. But the access to these interventions are very low almost all around the world, except for a few exceptions, such as the country we're in, the Netherlands and Australia, maybe one or two others. Much more work needs to be done to expand access to these interventions. Treatment has an impact here. If you add treatment, obviously you're decreasing the force of infection. Putting all three of those interventions together, you really have a very powerful, comprehensive package of interventions to interrupt transmission. So bringing all that together, you can, one model that was published in this past spring estimates preventing exposures to blood-borne HCV can avert 15 million infections by 2030, representing a 72% decrease in incidence. To interrupt transmission, and for those people who are already infected, where transmission has already occurred, obviously you want to prevent mortality. You have hepatitis B treatments that can reduce mortality, and then you have curative HCV treatments that can as well. Highly effective, as we've already have gone over and that most of us are already witnessing in our practice. Our challenge is that testing and treatment is poor in almost all parts of the world, both for hepatitis B and hepatitis C. So our challenge is how to increase that. We're really going to focus on hepatitis C here just as an example. You know, for many years, we had the cost of HCV was a formidable barrier. but thanks to generic manufacture supported by patent originators and local manufacturing, the prices of HCV medications have dropped dramatically, so that almost 2 out of every 3 people living with hepatitis C now live in countries where hepatitis C treatments cost less than $150, making these highly cost-effective, if not cost savings, in those countries. So really the cost of treatment is no longer a barrier to elimination. We've already heard from both Jordan and Philippa the move towards simplification, and that's very important. So again, a recognition of the safety and effectiveness of these treatments and the short course nature of these regimens really set it up well for simplified integration in high prevalence and primary care settings, and perhaps in community settings as well. So low cost treatment, highly simplified care. You have recommendations for testing that and so really how are those being implemented locally, and that's what we're here to talk about. I believe that many of the barriers around cure for hepatitis C have really fallen away. I think the major barrier is really speaking about testing. You still have this 2-step testing process. Some people fall through the cracks in that regard. You have centralized lab-based testing as an option, or point-of-care testing, as we've heard about, particularly with using GeneXpert PCR. But we have a lack of testing utilization. Number one, many countries don't have testing policies. Number two, as was identified in a CHI-FIND market analysis, a lot of point-of-care PCR testing equipment goes underutilized. And in fact, in that market analysis, they estimated that there was actually enough testing capacity in low and middle income countries to fill the needs for HCV testing if those platforms were fully utilized for HCV testing. At this point, they're not because of silos, patient flow, and other factors. There's wide variations in cost between countries for a variety of different reasons within the countries. Large volume testing is going to be required. So the utilization and the cost are important factors. I think there is a room for some technological innovations, particularly if we could get rid of this 2-step process and really have one test that would diagnose HCV infection and document cure. One prime candidate is an HCV core antigen assay. There's several private and public entities that are seeking to develop such a test and make it affordable so that it could be a replacement for this 2-step process. And we really need to make sure that we can make these interventions affordable for low and middle income countries, because that's where the greatest burden of hepatitis C is located. I want to show one quick example of an effective elimination program and the essential components of a testing and treatment program, and that's in Egypt, where in 2018 the President El-Sisi directed all adults to be tested for hepatitis C. This is after a long-standing recognition of high prevalence in the country and the development of a program for prevention and treatment that was already in place. They developed a financial-based planning that through negotiations they made antibody and PCR testing very affordable, as you can see there, and they had a $42 curative course of HCV treatment through a local manufacturer. They then did a public health approach to extend this testing throughout the community and clinical settings, linking people to a network of treatment centers, no patient co-pays, and in about 6 to 7 months, an estimated, well, it's not estimated, 45 million people receiving testing was documented in their database. They were able to do this through a combination of Egyptian government and World Bank funding. That resulted in a large scale-up in people receiving treatment there in the line graph on the left, and about a 99% cure rate among those people being tested for SVR. In some modeling that we just completed with Dr. Aman Waqid in Egypt and the Global Burden of Disease program in Seattle, the dark line was representing what GBD estimated was the path or projection of HCV mortality without this scale up. And then the second line shows you that there was a 61% reduction in mortality, representing a burden over 260,000 deaths in hepatitis C in Egypt. So that really shows you the power of an effective HCV testing and treatment program at a very favorable cost per ICER, or incremental cost effectiveness ratio. And that's without discounting for savings in not having to manage severe liver disease in future years. We're very interested at the coalition at helping countries make this decision about what's the right mix of lab-based and point-of-care testing that's needed. So we're in the process of developing a tool in collaboration with Dr. Jag Chatwal in Harvard. And we'd be happy to talk to you more about that when we have discussion and through breaks. So in summary, we have effective interventions to prevent transmission and disease. When you implement those interventions, good things happen. You have reductions in transmission, you have reductions in morbidity and mortality. I think the real challenge is the capacity needed to assure equitable access to these interventions in all countries, particularly low and middle income countries that have high prevalence. And we need to always continue to look to see how we can do better in our care models and our technologies to make this access to these interventions possible. Thank you.